Okay. Welcome, everyone. Thank you for joining us. If you wouldn't mind, when you start coming into the room, if you could put in the chat where you are joining us from this evening. Or this afternoon, depending on which coast you're on.
Right. Wow. Nice. Seattle, Frederick, Maryland.
All right, we're almost coast to coast at this point. Madison.
Wait for our first international audience member to join in.
That's right. You get a prize for that. All right. Thank you. So as you're coming in, if you'd let us know where you are this evening. Salt Lake City, Utah, a lot of Seattle, Vancouver, lovely. See, I shouldn't add descriptors because then it's judging which place is the nicest. Omaha. Florida, I think we've officially hit coast to coast now.
We have?
Yes. Thank you, Jacksonville.
Northwest to southeast. Hello, yes.
Where's Seattle? So we're just putting in the chat if you're just joining us this evening, or this afternoon, wherever you are, where you're joining us from today. We'll just wait another minute or so before we get started. Thank you all so much for coming today, this afternoon, this evening.
Hello, Lisa and Tacoma.
All right. More Los Angeles. Graduate program. All right. Okay. Thank you.
Bainbridge Island. Love the capitalized enthusiasm.
Apropos, it's quite a beautiful place, so makes sense.
It's where I grew up.
Oh yeah. Oh, you wrote that one. All right. Thank you, everyone, for joining us today. We really appreciate it. We know that for some of you, this is right in the middle of your day, so in the evening for others. You want to get started, Sean?
Absolutely. Absolutely. Hello, everyone. Good afternoon. I'm Sean Greenlee. I'm the DEI Program Manager for the Department of Medicine here at the University of Washington. We bring this lecture to you in partnership with the Institute for Common Power. We're excited that Angela Romaine will be presenting on Unveiling Maternal Morbidity and Mortality in the United States, Disparities and Challenges in Women's Health. And Dr. Terry Ann Scott will further introduce her in a moment. After Angie's presentation, we'll follow up at 4 p.m. Pacific Standard Time with a Q&A for those able to remain with us. Dr. Ivana Thompson, Associate Professor of Obstetrics and Gynecology from the UW Medicine and Associate Chair for Justice, Equity, Diversity, and Inclusion, will offer her insights and expertise. There will be space for questions after the presentation, and there will likely be space in the middle of the presentation for questions as well. So please enter questions into the Q&A section at any time. I would now like to introduce my colleague, Dr. Terry Ann Scott, Director at the Institute for Common Power.
Thank you so much, Sean, and thank you, Ms. Romaine, for joining us this evening. A little bit about the partnership and the Institute for Common Power. I'm the director of the Institute for Common Power and a professor of African American history. The Institute is the educational arm of a Seattle-based organization called Common Power, and Common Power mobilizes voters to help create social justice and racial justice across the nation. So the Institute has come into this partnership with the University of Washington Department of Medicine, and specifically Sean Greenlee, who helped create this partnership. And it was urged in large measure by Jordan Schulte, who is going to help us here this evening. She is an educational and healthcare advocate here at the Institute for Common Power, and she helps people understand that as we talk about voting and how everything is tied to voting, so too is the health of individual communities across the nation. And so the partnership itself seeks to address health equities in American society, which are, as you see, the unfortunate growth of historical systems of inequity based largely on race. And what we know is that when we point them out, when we recognize them, when we examine them, when we historicize them and talk about how we arrived at that, that's how we begin to dismantle those health equities. And we know that education then leads to action. And so that we very intentionally choose speakers in this diversity series that we have with the Department of Medicine who are interested in analyzing these issues and offering pathways forward for change. And that's exactly why we have chosen Ms. Angela Romaine to come and speak this evening. Ms. Angela Romaine is a dedicated healthcare professional with a strong background in nursing and a passion for advancing racial health equity. With a bachelor's of science in nursing from Arizona State University and a master's of public health degree from the University of Arizona, Ms. Romaine brings a unique blend of clinical expertise and public health knowledge to the forefront of healthcare disparities discussions. She currently holds the role of Vice President of Medical Operations at DeNova Collaborative Health, an integrated healthcare organization based in Phoenix, Arizona. And with that, I would like to turn it over to you, Ms. Romaine. Thank you so much for joining us.
Thank you so much for that wonderful introduction, and thank you all for the time today. Let me start off sharing my screen. Someone can just let me know if you can see it when you can see it.
Perfect.
Okay, perfect. All right, so as introduced, we are going to be reviewing maternal morbidity and mortality in the United States and how it disproportionately impacts women of color. I'll go through and pause for questions and comments as we make our way through the presentation. And also want to call out that this is really through a public health lens. My background is in public health, and so we're going to be addressing this for the public health crisis that it is, and how, again, women of color are disproportionately impacted. Like Dr. Scott just outlined, it's important to clearly define the problem so that we can efficiently dismantle it. And so we will follow and hope to answer the following questions. What is happening? Who is it impacting? Why is it happening? And most importantly, how can we fix it? So unfortunately, I start this presentation with a particularly heartbreaking statistic. 80% of pregnancy-related deaths are preventable. 80% of the deaths that we talk about when we look at mortality rates, and again, disproportionately how they impact women of color, 80% of those deaths were preventable. Again, particularly heartbreaking, but also hopeful to some extent. I'll refer to the statistic throughout the presentation to remind us all of the importance on following through on the call of action to the top of our ability. I know that our participants, we have a wide array of backgrounds. Some are experienced OBGYNs, and then others are not in the healthcare field at all. But we all have the ability to influence change and, again, address that 80% of these deaths that we talk about today are preventable. So we have the ability to change this, and we need to change this. So starting off, what is happening? Over the next few slides, I'll review some common definitions and terms to level set, again, given the wide background of this audience, so that we all have the same context as to understanding trends in data and, again, having a greater understanding of the subsequent call to action. Starting off with maternal morbidity. This describes any short or long-term health problem resulting from pregnancy and childbirth. So think anything that can impede a pregnant woman's well-being or functional ability, either during pregnancy or in the postpartum period. Some examples include cardiovascular problems, so heart disease, blood vessel problems, diabetes. When diabetes has an onset during pregnancy, it's referred to as gestational diabetes, but we can see this carry on into the postpartum period. High blood pressure. Again, during pregnancy, it's referred to as preeclampsia, but it can continue on into a postpartum. So after delivery, we can continue to see high blood pressure present in mothers. And then infections. So especially from a cesarean section, anytime, if you think about any time that you have a surgical intervention, there's always some sort of risk for an infection, either locally, so think at the site of the actual incision, or systemic, something like sepsis, which is widespread systemic infection that has severe consequences. When we talk about cesarean section in maternal morbidity, oftentimes these are unplanned operations, procedures. And so again, the risk of infection is higher in those cases. Blood clots, bleeding. We refer to bleeding oftentimes as a hemorrhage or maternal hemorrhage when it happens at the time of delivery. And then finally, depression and anxiety. I'm going to really call out depression and anxiety here because we have a separate mental health crisis that impacts our nation. And this was exacerbated during the time of COVID. We have seen rates of suicide skyrocket across the country. And there's a good chance if you don't know someone that you've lost to suicide, you know someone that has. And so really want to call that out because it is so pervasive in our society and not just specific to maternal health outcomes. Another point that I'll make before moving on to the next definition is morbidity often comes with a longer hospitalization stay or increased emergency department utilization. So lots of unforeseen visits. This is associated with increased medical costs. And so while the focus of this presentation is going to be public health lens and really focusing on the health outcomes within this population, it's important to just have the context that there is a very big financial repercussion associated with maternal health outcomes, and specifically when we're looking at maternal morbidity. Next definition, maternal mortality. Straightforward. It describes the death of an individual from complications related to pregnancy or childbirth that occur either during pregnancy or within the 6 weeks after pregnancy ends. That 6-week or 42-day mark is referred to as the postpartum period. It's important to note that this is regardless of delivery method when we're looking at data throughout today's presentation. So whether that be a vaginal delivery or a cesarean delivery, 6 weeks is that standard definition when we're looking at these specific data sets. And then moving into risk factors. 2 categories capture the bulk of our risk factors, so individual and systemic. For individual, their objective findings is the easiest way to describe them. The leading risk factor is advanced maternal age. ACOG, or the American College of Obstetrics and Gynecology, currently defines advanced maternal age at 35 or higher at the time of delivery. And so you could potentially conceive at age 34, but if your delivery date happens to land after your 35th birthday, you are officially old when it comes to maternal age. So just pointing out that clarification there. Pre-existing conditions, major comorbidities that we see in the pregnant population is obesity, diabetes, hypertension. All of those pre-existing conditions can put you at an increased risk when you're actually pregnant. Cesarean delivery and perinatal mental health. So like I referred to in the morbidity slide, both of those things can create complications. So cesarean delivery, again, often can be unplanned or an emergent response or intervention to an existing condition. And perinatal mental health looks at the entire period, so before pregnancy, during pregnancy, and after pregnancy. And so it looks, again, at that spectrum, that time frame in totality, and it considers the associated risks to the mother. Systemic, so moving over to our second category of risk factors. This is less understood and not as commonly acknowledged as it should be. And that really is going to drive a lot of this topic in this presentation today. it's difficult to define overall and really identify a singular root cause. When you take into consideration that despite spending more on maternity care than any other country, the United States has seen maternal deaths rise since 2000, and the risk of death from complications related to pregnancy and childbirth are greater in the US than in any other high-income country. Furthermore, the risk of maternal mortality is unevenly distributed. Women of color are dying at 3 to 4 times the rate of their white counterparts. Social determinants of health, and specifically structural racism, feed into the systemic risk factors. And I'll talk at length about social determinants of health and really how the precursor to that is structural racism and how that impacts our maternal health outcomes in this country. This is a visualization of what I previously outlined. A lot of I'm going to call out the standard rate that we'll look at in the majority of this data that I'll present today is at deaths per 100,000 live births. So it helps to standardize that ratio so we can compare different populations in a standard way. You can see the US is far and away where that top dark gray black line, so leading the charge there, unfortunately, in maternal mortality rate. This is just looking at the time period of 2018, 2019, and 2020, but we'll expand on that timeline so you can kind of see how it's trended overall. And then I'd be remiss to not talk about COVID and how this has impacted our maternal mortality trends. This is looking at raw data, so maternal death counts. This is not standardized per 100,000 live births. So date range from January 2019 through some provisional 2023 data. You can see that we had our biggest spike in line with our biggest spike in COVID rates that we saw across the country, which makes sense when we consider from a public health lens that there were so many preventative health measures that were not being followed because of limitations due to quarantine, access to care. And so prenatal care fell into that as well, as you can imagine. And so we are trending down. You can see January 2023, we're right about back to where we were pre-pandemic. But again, going back to this slide, where we were pre-pandemic was not good. And so we cannot be satisfied with this slight decrease in maternal death counts. It's encouraging to see that COVID is no longer a factor, and that we really need to get back down to what our cause is overall and how we can influence it. So the next category that I will talk to is who is it impacting? Who makes up those mortality trends? So this slide is breaking down our maternal mortality by race. Again, this is that standard ratio, deaths per 100,000 live births. So this is not a raw percentage when you're looking at these numbers. I'm going to give a quick orientation to this slide. All the way to the left, that cluster of columns, that's looking at total mortality across the country year over year. So each one of those columns represents a year: 2018, 2019, 2020, and 2021. Those years carry over to the subsequent groups that break that overall total down by race. So second to the total group is our non-Hispanic Black population. That is followed by non-Hispanic white, and then finally Hispanic mothers. So very obvious here, 2.5 times the mortality rate exists in Black women when compared to their white counterparts. And this is year over year. So pre-pandemic, we saw those same disparities. You can see that it's continued to trend up in line with that total mortality that we see all the way to the left, but a very wide discrepancy when you're looking, again, year over year and comparing non-Hispanic Black women to white counterparts. This is same time frame, so same measurement period. This is looking at mortality rate, but broken down by age. So 3 groups: under 25 population, then followed by 25 to 39. So we have some of our advanced maternal age falling into that bracket. And then it steeply increases at 40 and over. So how does age and how do age and race intersect? That was my first question. And looking at both of these, right? Because you see 40 and over has that steep increase in mortality rate. This table, there's a lot of information on it, but really just want to focus on that red rectangle highlighted in the middle. That is looking at the maternal mortality rate again, so per 100,000 births for 2019. I intentionally chose 2019 on this slide because it's pre-pandemic, so it removes COVID from the calculation to some extent. And then really focusing on non-Hispanic Black, so Black women when compared to their white counterparts. And then this is cross-referencing age, so same age groups as we saw on the previous slide. So when we look at the top of that red rectangle, that is the raw, not raw, but the total rate for Black women in 2019 per 100,000. The next number, or 18.8, is looking at the under 25 population. I'm going to slide down a little bit to the under 25 population for white mothers during that same time frame. They were down at 13.1. So a difference, but not as stark as when we move into 25 to 39. And that's where you have to think that's the bulk of our childbearing mothers fall into that 25 to 39 age bracket. That's also, there's some advanced maternal age, again, 35 or older, that fall into that age group, but the bulk are 25 to 35. And so that's where the divide really widens. Black women in the same age range, so we have 49.7 compared to 16.8 for white women in that 25 to 39 age bracket. That is astounding when you take that and looking at that age range again and trying to standardize that across the spectrum. That 25 to 39, there's that huge jump, and it's really just accounting for race alone. And then we see an increase, continued increase when we look at 40 and over, 166 per 100,000 for Black mothers when compared to 75 per 100,000 for their white counterparts. So again, you see that continued wide divide, but it's really worth calling out 25 to 39. It's not 2 times, it's 3 times the rate that we see Black mothers represented in mortality trends. And then who is this impacting? We need to put some faces to some of these numbers, to some of these statistics. And I call out this group specifically for a few reasons. One, these are elite athletes. They are in pristine condition physically. And then they're also women of a certain status. Serena Williams is very well known in most of the population and has, the means to be able to have the best healthcare, access to the best healthcare in the world. Allison Felix is also an athlete that was impacted in maternal morbidity. Serena Williams had an emergency C-section, which was secondary to her voicing concerns during her delivery that she was having difficulty breathing and was pretty sure that she had what's known as a pulmonary embolism or a blood clot in her lungs. And she had this, she had a history of a pulmonary embolism, so knew what the associated treatment would be. And so was to the point that she was directing, I need this type of medication, I need this type of imaging. She was advocating for herself, as we encourage patients, women to do, and still went unheard. Again, this is someone that is a public figure and still fell into that maternal morbidity data set. How does that happen, right? There's something more than just those traditional risk factors that I initially presented. Race is absolutely a factor here, and implicit bias, which I'll talk about later on in the presentation, is absolutely at play. Allison Felix, similarly, she had what's known as preeclampsia, so high blood pressure during pregnancy. She had symptoms, but really wasn't aware of what to look out for. She had to have an emergent C-section 2 months before her due date. Thankfully, her and her child survived and didn't really have any long-term consequences. Which brings us to Tori Bowie. So the beautiful woman that's there in the middle of our screen. She suffered what's known as eclampsia or seizures during pregnancy. This can come subsequent to a high blood pressure or preeclampsia in pregnancy. And she was found at 8 months pregnant, expired in her home. She was alone at the time of her death, and her daughter also did not survive. And so again, these are women that are in the best health status that you can be. They're elite athletes and are well educated and are privileged when you think about it from that classic socioeconomic level. But again, fell into that maternal mortality rate that we're seeing that disproportionately impacts women of color. So I'm going to pause here before diving into the next section of why, exploring more of why is this happening. Allow time for any questions, clarifications that may have come through in the chat. Jordan, is there anything that you'd like to share that I can help answer or clarify before moving on?
Yeah, there was a couple questions, I think.
Sure.
Oh yeah, I think Sean mentioned as well. Yeah, people were asking about data for Indigenous, Native, and Asian populations, impacts in specific regions and states, and Dr. Thompson kind of answered those briefly, but
perfect. Thank you, Dr. Thompson.
Yeah, but I'm not sure if the rest of the audience can see those or hear those, so if you have any insight on those too, I'm sure they'd love to hear.
Yeah, there's absolutely, so there's so much data and trying to pare this down a little bit and be conscious of time, really focused on the main studies that are coming out from the CDC, the way that women of mixed race and, like you mentioned, Asian and Indigenous populations, there's data available for those. I just don't have it included in this slide, but there's absolutely, it's absolutely available. And when you're talking about geographically, how this is distributed across the country is what I'm assuming that question is clarifying. We see it in, kind of falls in line with if you looked at a US map of Medicaid expansion and the staggered rate that that followed that during the pandemic. And so it happens a lot in the South. We see that at higher rates and lower rates on the coastal regions.
Ms. Romain, there was one more question in the question and answer about the race of the doctors and the nurses in those cases of the women who died.
That's a great, I do not know that specifically, but that's a great research question. And that's as we get farther along, research is something that an implicit bias and really training our healthcare teams. That's a great call out. And I think it would be an excellent research topic if it's not already. A great consideration. Okay. I'm going to move on into why is it happening. So bringing forward that statistic of 70 deaths per 100,000 births, that's specifically looking at our Black mothers from the 2021 timeframe. And so calling that out, because again, it's important to think how that 80% of preventable births fell into that. What could we have done different for that population? We'll focus on just 3 strategies to consider when we're looking at why is it happening. But again, it's important to call out that this is obviously a very complex situation. And again, from some of the questions that were brought forward, it doesn't just impact Black women. It impacts different areas and different races as well in a disproportionate way. And so again, we'll focus on just these 3 contributing factors over the next few slides. Starting off with something called allostatic load. Allostatic load essentially describes the cumulative psychological and physiological impact of stress over the life course. So that is not specific to maternal health, but when you take into consideration the stressors that just naturally occur with pregnancy, it's important to consider both at the same time. Clinical implications of that, when we're thinking about traditional individual risk factors, is how that chronic stress manifests and impacts and really expands that group, especially in advanced maternal age, considering that 25 to 39 population at large, right? So how does allostatic and chronic stress, allostatic load and chronic stress impact that group? It's a visual flow chart of that model. So to the left, we're looking at psychosocial factors of stress, traumatic experience, environmental stress. Think structural racism, how those can fit in and really define those experiences. This looks like a linear model with a start and a finish, but it truly is a cyclical theory. And so we need to consider how generational traumatic experience and stressors feed into those factors of stress. That feeds into a chronic stress state. So with a chronic stress state, you might not see it objectively. The mother might look like they're getting what they need to get done. They're going about their days. But again, if anyone has heard of the phrase, the body keeps score, that chronic stress state is having physiological impact behind the scenes that sometimes even the mother doesn't realize. There's genetic, epigenetics, so really the way that the cellular response systems are able to function that impacts our central nervous system, vascular system. So think increased risk of heart attack, stroke, immune modulation, so ability to fight off illness. And then again, like I previously mentioned, compounding with already the biological stressors that pregnancy just has naturally. So it just compounds that problem and stress state. So we'll see that in maternal health outcomes in both morbidity and mortality, but it's important to call out here the adverse fetal and infant health outcomes that can be associated. And that again feeds into the cycle aspect of an allostatic load theory, because that can carry on again at the generational level. So again, clinical considerations really need to look at what generational stressors might this population be facing. And then it also explains some of the maternal morbidity and mortality by race, regardless of socioeconomic level and age, how we see that race is really identified as the determining factor for health outcomes. Again, individual risk factors, so hypertension, diabetes, obesity. So those conditions existing pre-pregnancy also can have some ties to an increased stress state. So when we're considering allostatic load in this, stress is a contributing factor to each one of those to some extent as well. And so you can see how those carry over into that presentation. And then again, advanced maternal age. There are several studies that cite that Black women biologically age at approximately 10 years faster than white women. There's telomere length and different clinical indicators that support that theory. But it also, when we're looking just at raw numbers, that really provides a good context as to why, again, calling out specifically that age group of 25 to 39, why there's such a huge divide between Black and white mothers, which goes into social determinants of health, or SDOH. These are essentially the conditions in the environment where people are born, live, learn, work, play. So where you exist, and how that those conditions can determine your quality of life, your health outcomes, and identifies any social risks associated. This can overlap with allostatic load as well, because you have to think if you have a higher risk for different social risk factors, or higher incidence of social risk factors, you fall into that allostatic load of chronic stress from those environmental stressors. Clinical implications, it's important to consider SDOH when we're looking at access to, for an individual to be able to reach vital resources like housing, transportation, and of course, healthcare. This next slide is looking at 3 separate factors that shape an individual's health status. And so social determinants of health, by collecting that data, assessing that population through that lens, you're able to stratify the social risk factors of the population. So to the left, the smallest percentage, 20%, is attributed to individual care interventions. So think of that as medical care when you think of healthcare, right? So your prenatal visits, having a safe labor and delivery, a hospital that is prepared to serve you and within access. And then finally having the resources in the postpartum period. And then shifting over to the middle, 30% falls into health behaviors, is what shapes an individual health status. Health behaviors are choices made by the individual. So dietary choices, exercise, activity level, substance use, so think alcohol, tobacco use, fall into that 30% of health behaviors. And then shifting over all the way to the right, 50%, so the vast majority, is looking at socioeconomic and environmental factors. And so social determinants of health fall into that 50%, but there's also a lot of overlap between the socioeconomic and environmental category and how it directly influences health behaviors. So I'm going to give you a couple of scenarios on how that breaks out. You have Mother A that is pregnant with her second child. She has a toddler at home. She lives near a well-maintained park. There are adequate sidewalks and bike lanes in her neighborhood. She can bike to the park with her toddler that's at home. She lives near an ambulatory care center. It's even within walking distance. Her OBGYN is housed there. Around the corner, there's a health food store. So access to fresh produce and different healthy choices for food for her and her family. She has her own transportation, but if in the event her car is in the shop, she has access to a light rail station and also within walking distance, and it's safe and an alternative way to get to where she needs to go. It's easy for her to make. There's not a lot of barriers in that scenario, right? When you're thinking about making a healthy dinner for your family, physical activity. She can easily walk and ride a bike and navigate her community to have that increased activity level. She doesn't have any barriers to transportation when we're talking about access to healthcare in that prenatal and then postpartum time period. Cross-reference or juxtapose that with Mother B. She's pregnant with her second child as well. She has a toddler at home. The nearest park is about a 20-minute drive. Her neighborhood has poorly maintained sidewalks. Some of the blocks in the neighborhood don't have sidewalks at all. There are no bike lanes. There's a lot of high-speed traffic near her home. She doesn't have reliable transportation, and public transportation is a bus stop that's about a half mile away. She has to commute to get to her healthcare provider, and she lives in what's called a food desert. The nearest food source is a convenience store or equivalent to like a dollar store, and so has a lot of processed prepared foods there. When we're talking about her health behaviors, we can educate Mother B, till we're blue in the face. She can have everything that she needs to know about how to take care of herself, right? How to achieve optimal health. But if we neglect to assess the barriers that she has in her socioeconomic and environmental aspects of her life, the health behaviors will never be achieved. We'll never see, she doesn't have the same capability that someone that's in a different living situation has. And so really it's 80% when you look at both of those things combined and consider the direct impact that they have on one another. That is what shapes a lot of our maternal health outcomes. We need to address both of those things at the same time. Social determinants of health are 5 domains. So similar to the situation I just described, you can see there's a patient there at the center, and then they're all kind of intertwined: healthcare access, neighborhood, societal, social community context. So having the support systems available, community resources available, economic stability, and then finally education, access and quality as well supports that healthy community. Going into implicit bias. Implicit bias is a subconscious bias that impacts our attitudes and beliefs towards race, ethnicity, age, and gender. It's very important to call out that it's subconscious and that it affects our attitudes, everyone. This is not positive, negative, you're racist, you're not racist. Everyone, it's a spectrum. Everyone has an affinity one way or another, whether they realize it or not, to different race, ethnicity, ages, and gender. There is, if you have not taken it already, the Harvard's implicit association test. It is public facing. There are, I think, a dozen or so different categories: race, age, gender, are just a few examples. Takes maybe 10 to 15 minutes. And again, it gives you kind of an idea of where you fall in that spectrum. The clinical implications, we can see associated diagnostic delays, less patient-centered care, and undertreated pain. And so like the case with Serena Williams, where you had someone that was absolutely clearly identifying, and she was right, what was going on, there were still associated diagnostic delays. She was not the center of that care plan, and her pain went untreated. Why did that happen? What was going on there? We have to identify the role that implicit bias played in that scenario specifically. So again, it can be difficult to recognize. These biases are learned from cultural exposure and internalized over time. One study, this was from 2015, cites that approximately 50% of US medical students surveyed reported having been exposed to negative comments about Black patients by attending a resident physician's. And those students demonstrated significantly greater implicit racial bias in year 4 than they had in year 1. And so again, we need to identify what the problem is and how implicit bias is absolutely a factor in it. I think it's really hard for people to do and be willing to do the introspection that's necessary to identify and define implicit bias, but we need to take the ego out of it and really expand this to our healthcare workforce, because there's absolutely no room to not, right? We need to clearly define what the problem is, and this is absolutely a factor to consider. And finally, last section is our call to action. Any other questions, Jordan or Dr. Scott, that you'd like me to pause and respond to before diving in?
Not yet.
Okay.
If anyone has any questions, please feel free to drop them in the chat as we get to the end of the conversation. Then Angie will answer them, and then Dr. Thompson will come in as well.
Perfect. So as I previously stated, very complex problem. We need a multifaceted approach to this. Proposed solution is a very high level, and as we'll talk over the next few slides, upstream approach. So that the proposed solution is the medical community addresses this critical issue through an upstream public health framework. See that upstream is highlighted. For those of you that don't have a public health background, a medical background, I'd like to take a moment to illustrate what an upstream approach is. So I'll have you take a breath, shake it out, close your eyes if you're comfortable in doing so. And I'm just going to tell a quick story that illustrates upstream intervention. Imagine a warm, sunny afternoon. You are sitting by a river with your family having a picnic. Suddenly, you spot someone in the river being swept downstream and struggling to stay afloat. Without hesitation, you jump into the river and help the person ashore. As you help that person dry off, you hear another cry for help. Someone else is being swept downstream. Immediately, you jump into the water again and pull out the second person. This scenario continues all afternoon. As soon as you pull someone safely to land, you have to jump back in and save someone else. Finally, you say, I can't go on like this, and walk upstream to see what's happening. As you walk upstream, you warn other bystanders. People are falling in the river. Please help them. Tell everyone you know. Finally, you find the problem. You notice a large hole in a bridge, which is causing people to fall in. Something must be done. First, you put up a sign to warn others about the hole in the bridge. You warn anyone you see about the hole and ask them to help spread the word of caution. You even start offering classes to help people in the community learn how to swim just in case they do fall in. Finally, you realize that to truly minimize the problem, you have to repair the bridge. You work with others in the community to close the hole. Occasionally, some people still fall in, but there are fewer people that need to be saved. So that is a story. There are different iterations of it that we commonly use in a public health education background. And it provides a little bit of context as we look at this next slide, which illustrates that upstream approach. So when we're looking at upstream intervention, so repairing the hole in the bridge, consider community impact, so state and even national level. The strategies and tactics